Good morning, everybody. Today we are going to talk about the obstructive jaundice according to MRCS Part B. Let's talk in this topic by question and answering, okay? If the patient is presented by epigastric pain, nausea, vomiting, diarrhea, and there is dark urine and pale stool. When we do the lab test, there is elevation of ALT, GGT, and increased total bilirubin. This kind of investigations tell us that there is an obstructive jaundice. Obstructive jaundice, it is a jaundice that occurs due to obstruction in the biliary tract. This is the liver, and this is the common hepatic duct, right and left hepatic duct, and this is the hepatic duct, this is the cystic duct, and this is common bile duct. If there is obstruction here, there will be obstruction of the jaundice, so the bilirubin will be elevated. Right, left hepatic duct, right and left hepatic duct, and this is common hepatic duct, cystic duct here, and this is common bile duct. So, in what form does the bilirubin circulate within the plasma? It is circulating in the three forms, okay? Free bilirubin and conjugated bilirubin, and finally bound to albumin. So, can you tell me how the uropylenogen formed and how it circulates? Uropylenogen, it is colorless product that is formed by metabolism that is formed by deconjugation of bilirubin by the gut flora. Deconjugation of bilirubin by the gut flora. Some are excreted in the feces, and after oxidation, there is some reabsorbed into the portal circulation again. And some are reabsorbed, some of reabsorbed uropylenogen is again excreted by the liver. Reabsorbed uropylenogen is re-excreted by the liver, but a small amount are entering the systemic circulation and are excreted in urine. So, why it is absent in urine? Why it is absent in urine? Because there is an obstruction of the flow of the bile, as we said before. Obstruction of the flow of bile and bilirubin, so it can't reach the gut. Can you tell me what is the physiological role of bile salts? It is important in digestion, fat digestion, bile salts, in fat digestion and absorption. It formed something like measles, which helps to it helps the fat absorption and the digestion by emulsification. Of the fat into measles or measles. Thus, it is greatly increased the surface area and it helps the action of lipase enzymes. Okay, can you tell me how the bile salts help in emulsification of fat? Bile salts are bile salts, hydrophilic, okay, on one side, and hydrophobic in the other side. They aggregate around the droplet of the lipid. Okay, this is the droplet of the lipid. They aggregate around the droplet of the lipid. Form measles. With hydrophobic side towards the fat. This is hydrophobic. And hydrophilic side outside. This is hydrophilic. The hydrophilic side are negatively charged. And this is charge prevent fat droplet coated with bile from reaggregation into larger fat particles. So this is negative charge will cause something that take the lipid away from forming larger molecule of fat. So the hydrophilic part, the negative charge, helps to make the fat more smaller. Okay, as we mentioned before, one of the forms of the bilirubin, it is conjugated bilirubin. So to which molecule does this bilirubin conjugate? To something called glucuronic acid, by an enzyme called glucuronide transferase. Let's talk about bilirubin metabolism. Bilirubin metabolism in the small intestine. It is conjugate to bilirubin in the bile. Bilirubin in the bile, forming in the small intestine, and reabsorbed to the enterohepatic circulation reabsorbed in the enterohepatic circulation. But the conjugated bilirubin is not absorbed, and instead it passes into the colon. Okay. In the colon, the bacteria in the colon or large intestine the bacteria deconjugate the bilirubin into uropylenogen. This is the gut flora. 50% are oxidized by bacteria forming stericopylenogen, which is brown in color, while 50% reabsorbed again into the enterohepatic circulation. And part of it, only small part of it, go to the urine to form uropylenogen. Okay, can you tell me why there is coagulopathy in the obstructive jaundice? Coagulopathy due to two reasons. As we said, this is the liver and this is right and left hepatic duct. This is common hepatic duct. This is cystic duct. This is common bile duct. If there is obstruction, the bile will go back by back pressure into the liver, and this is may cause hepatic fibrosis. And this liver fibrosis or cirrhosis will affect the coagulation pathway, as the liver will form all coagulation factor. In the liver there is all coagulation factor except factor 8 from the endothelium, by the way. So if there is any obstruction in the pathway of the bile, there will be back pressure on the liver, causing hepatic cirrhosis, causing affection of the coagulation pathway. Number 2, there will be affection of all vitamin that is need lipid to be reabsorbed, like A, D, E, K, which is called fat soluble vitamin. Okay, if there is affection of vitamin K, there will be affection in the coagulation pathway. Vitamin K dependent factor, which are 10, 9, 7, 2. They will be affected due to affection of vitamin K, which due to affection of the reabsorption of or absorption of fat, so it will be affected. So we will do in the lab test INR and the prothrombin time. So how can I correct the clotting abnormality? By vitamin K, 10 milligram for 3 days. And if there is much bleeding and I need rapid correction, I will give fresh frozen plasma and the prothrombin complex concentrate. How the enterohepatic circulation maintain the bile salt in the healthy adult? What is the definition of the enterohepatic circulation? There is reabsorption of bile salts from the terminal ileum and return them back to the liver. This is the definition of enterohepatic circulation. More than 95% reabsorbed again. And liver senses a small amount every day and replace the amount of bile lost in feces. What could be the cause of silent obstructive jaundice? It is due to cancer, head of pancreas. As we mentioned, this is our drawing. And this is the duodenum. Here is the pancreas. If there is cancer in pancreas, it will obstruct the duodenum and it will cause obstructive jaundice and it will cause back pressure on the liver. What the investigation that should I do if there is a stone in common bile duct? I will do ERCP. It is a diagnostic and a therapeutic. If the patient has fever, pain, and chills, what is the cause and diagnosis and how to manage it? It is ascending cholangitis. There is a triad of fever, jaundice, and the abdominal pain. This triad means that there is ascending cholangitis. And the management will be according to CRISP protocol. I will manage the patient in the ICU and I will perform high flow oxygen, IV fluids, antibiotics, blood culture, chest X-ray and urine analysis, and urine, and I should calculate urine output. As we mentioned before, that ERCP, it is therapeutic also, so I can manage it by ERCP, and if there is severe obstructive jaundice, I can manage it by emergent biliary drainage. What kind of antibiotics that I should use in the ascending cholangitis? I will use third and fourth generation cephalosporin plus metronidazole. Could we use esophagoscopy for ERCP? No, because there is an opening of the esophagoscopy is anterior, and in ERCP is on the side, so we can cannulate CB common bile duct. I hope that you get benefit from this lecture. Thank you for studying with me. Don't forget to like the video and subscribe the channel. Bye.